I'm Herb Harmon, like you just heard. I'm a psychiatrist, a general adult slash, or I should say just general trained. And I mentioned that I did not do the child and adolescent fellowship, so my child and adolescent friends like to remind me that I am partially trained. But I still do actually cover adolescent units from time to time. Just a little bit about myself. I think it's helpful to introduce my lens, because I'm asking everyone to think about calming techniques, de-escalation, with the idea that we should constantly be curious about how we might change our behavior. So why would you take any advice from me on how to do things differently if you didn't understand where I'm coming from? I also want to invite you to, this can be as dynamic as you'd like it to be. I prefer it to be a little dynamic. It's not that much fun to have someone lecturing at you. It's not very productive. You can always read a book if you want, right? But here we are in the same physical space to share ideas. And we don't have any, we don't have dogmas. We have really great ideas that have been tested that can allow for, when we can allow new ideas to come in, and then we can share in that together and just keep making patient care even better and better. So like you just heard, I live in South Carolina. I'm from Northern Virginia, outside Washington, D.C. Went to medical school at the University of Virginia. So often when I'm in the Southeast and you hear like, oh, you're with this California company. Not really, we're national. I've been in and around the Southeast, and hospitals are hospitals. So thankfully we're able to deploy this method just about anywhere, but it's always a little comforting to know you've got people within your organization that have been in and out of some of these same cultures and ecosystems. I trained at UPMC, Pittsburgh, for residency training, and actually just got to see Dr. Alil Salai, who was one of my attendings there. He's now with MUSC, so that was super cool. I didn't even know he was down here. So that was very exciting. And then I was 4 years active duty with the United States military. I was a combat operational stress consultant in Afghanistan. So some of what I've learned about de-escalation is, literally working with special forces guys on the Pakistani border who have become manic for one reason or another, and holding a loaded weapon. I've got 2 loaded weapons, they've got a couple, and I need to help them understand why they need to get on this Black Hawk with me to get back to Bagram. So those, so if that technique can work there, I guarantee you it can work here. My introduction to emergency psychiatry and verbal de-escalation really was probably at Western Psychiatric at UPMC in Pittsburgh. We had a 13-story, 270-bed psychiatric hospital with a very busy psychiatric emergency room. And as an intern, you get baptized. Welcome to being an actual doctor. Tuesday night, you're the only doc in the house, 270 beds, very busy psych emergency room, you and a bunch of nurses and social workers, you can do this. And you learn very quickly what works and what doesn't, right? And so that was my introduction. Since then, I've lost track. Now with Vituity, I'm an associate vice president for psychiatry. I have about 80 psychiatrists that work for and with me. I have about 20 advanced providers as well, so it's about 100 of us. We have about 30 contracts. I've been credentialed at about 30 hospitals in the last 8 years. I have, I think, 10 different state licenses on and off at this point. So I say that just to give you some idea that these techniques that we talk about, they work everywhere. And they never work perfectly anywhere either, right? So that's why we have to constantly do research, and we have to learn from each other and share in some of these ideas. So thank you for having me. So that's the lens I come with. And right now, clinically, I work a lot with Sutter Health Hospital out in the Bay. And yes, we have a very robust, busy telepsychiatry program. It started with me living in my home office 24/7 to keep it afloat. And now I've got a whole team that does it round the clock. And I can't remember the last time I was on video for that panel recently, because they've taken it over. It's fantastic. First part, agitation is an acute behavioral emergency. Any idea why this is super important to mention? Notice there's an absence of a specific word. psychiatric, right? Agitation by law is a medical emergency just like a heart attack or anything else. And part of why I mention that is just to remind us that you're not treating psychiatric illness specifically under the way most federal and state regulations would say has to follow under certain guidelines. The idea being that when you have agitation, if you look at the fMRI studies, you look at neurochemistry, everything, it's a physiologic state. People don't decide to become agitated. They are agitated. And if you don't treat it, someone could die, right? So when, for instance, you're on an inpatient psychiatric unit, there's a lot of steps you have to go through before you can prescribe, say, risperidone or Risperdal for schizophrenia. You need to make sure that the patient understands what their diagnosis is. You need to make sure that you've gotten full consent, that they've been educated, risk benefits, side effects, and alternative treatments. When someone is seizing, right, and you have to stop the seizure and you're worried that they're going to aspirate or their oxygen saturation is going down, you don't pause and have this long conference about the ethics and of all of this and inform the family and inform the patient. You give them, probably a sedative, a benzodiazepine to stop the seizure so you can get them well enough to actually have that conversation. So in medical legal terms, agitation is the same thing. So we want to understand it that way. We don't have to necessarily go through every single step. We're just trying to actually treat the problem. Preferred intervention for calming is verbal, right? Medication can help, and it's part of the verbal de-escalation. But unless signs and symptoms dictate emergent medical intervention, de-escalation must take precedence in an effort to calm the patient. Anyone ever here seen someone be given an IM without a conversation? Even once? Maybe not. I have a lot. I see it less and less. So I think a lot of this is catching on. But as you can imagine, if you just try to imagine feeling agitated in an emergency room and what it would feel like if someone approaches you with an option or a choice, or if they're just coming at you with a needle. So Zeller, this is referencing Dr. Zeller. He's our vice president for psychiatry that I work with Vituity. He's at the airport on his way to Scotland to spread the good word. There's a number of, it's not just in the US that a lot of these concepts are taking hold. And he's got 6 things. And I think what's interesting here is, I think 3 of them almost everybody agrees on, and then the other 3 are where the real work comes in. Exclude medical etiologies that ensure medical stability. At least on paper, everybody agrees to that. Every emergency room in the country is going to say, yes, we do that. Rapidly stabilize the acute crisis. And then for the most part, people are going to agree on that. They're not necessarily going to agree on the techniques. But here's the next 3, I think, are where it gets really tough. This is where we have to do the work. We have to dig in. Avoid coercion, right? Do this or else. Not very collaborative, doesn't feel great. As a patient, that's not kind of where you want to live. Treat in the least restrictive environment, right? So if patients have freedom of movement and they have some sort of choices and they have access to things that help them feel safe and calm, we want to make sure those are around. Form a therapeutic alliance. That is also tremendous amount of effort to get everybody in that same place where they're genuinely bought in this idea that this person who's suffering greatly deserves a piece of what they bring to the table, their actual self, the reason they went into medicine and want to work in healthcare. Is that being brought to the patient? And then the last one, formulate an appropriate disposition and aftercare plan. So what I think most often we're doing, sometimes we have to go back to number 1. I got referred a patient who had apparently, he had a normal gait and station, and then he came to me and it turns out he was a double amputee. Somebody forgot to actually do the physical exam, so we see that get skipped, but it's easy to go back to number 1 and say, hey, we got to do number 1, but 3, 4, and 5 are super tough to get everybody on board with, but we're paying attention to all of these. So with verbal de-escalation, the goal is to help the patient regain control so that he or she can participate in the evaluation. So while engaging the patient in verbal de-escalation, the clinician's observations of medical judgment must drive decisions. Successful de-escalation is the key to avoiding seclusion and restraint, right? So everybody agrees, working in emergency services, if we can decrease length of stay in general, that's a pretty good thing, right? And so to get someone out of the emergency room, generally, you need to be able to engage them. Even if you're sending them to an inpatient psychiatric facility, they need to be well enough to say, hey, we're sending you here, you're on a commitment, let me give you a copy of your rights. All of these things have to happen. Guess when is it that you can't do that? Anyone know? When you can't talk to someone when they're sedated, right? To the point where they literally are not awake, right? So one of the things we like to remember, we want to remember, is it's not just about your shift or the next shift or whatever, it's about this patient's trajectory, right? And so if you've got 1 hour left in your shift and it seems like the fastest path to get what you need is to make sure this person gets a bunch of medication without engaging them, that does get you through your hour. But you've basically bought the next shift of sleeping, and then the shift after that, maybe we'll get to engage this person. So these things are all happening at the same time. We're trying to avoid this last one, right? We're trying to do the psychiatric evaluation, we're trying to conduct the medical evaluation, we're trying to offer medication, and at the center of it, all of us need to be working to de-escalate. Even if different people are mostly working at these different things, everyone has to play a part in this. You can't wait for the psychiatrist to de-escalate. If you're waiting for that, the culture is probably, and the milieu is probably so bad, there's not much the psychiatrist can do at that point. Benefits of mastering these skills. It usually takes less time than restraining someone, right? Restraining somebody is a lot of resource, a lot of time, energy. Sometimes I feel like, I can't spend 10 minutes talking to this person. Well, then why would you spend 20 minutes restraining them and secluding them? I think mostly what you're saying is like, it doesn't feel right. I don't have the confidence to try, right? And that's normal. It's not an easy thing to work through verbal de-escalation. We want to, avoiding containment procedures will result in less injuries to both staff members and patients, right? So pretty obvious, except for when tension's really high, it's not necessarily emotionally intuitive. So you have to rehearse when you're in a place like this to say, yes, this is true. And then that it becomes automatic. Patients are more trustful when not restrained or forcibly medicated. Seems obvious, but nice to remind ourselves this. And last one, definitely true. Anyone ever seen someone, they're trying to send them to psychiatric inpatient, and the unit manager or somebody, a chief social worker who last month, remember, somebody shoved them or did something that made them afraid, says, oh, this person was in restraints 6 hours ago. We're not looking at that until tomorrow, right? And so now this person's waking up in an environment where they've already been restrained, so they're already scared, they're already anticipating a fight, and now this receiving facility is telling you, good luck, do it differently the next 24 hours and we'll reconsider. Think this only applies to low acuity patients, question mark? This is a look at forensic inpatient unit. No. Turns out being collaborative in terms of how you're prescribing, using de-escalation techniques, modifying your environment, and having the ward manager, I think this is super key here. Ward manager role modeling therapeutic intimacy and nurse-patient relationships. And they found that when implemented, seeing better outcomes. So even with super high acuity patients, we see much better outcomes when these principles are applied. And we just kind of hinted at this, but here's some data. 4.2 hours longer on average when you end up having to use restraint and seclusion, right? So we're not always chasing numbers. We really are trying to decrease suffering. But for those of us who are commonly under the gun to actually chase numbers anyway, we're trying to do both at the same time, this is how it works. We want to do the very best for the patient, and sometimes that also means serving the system so we can, move in parallel. So 10 commandments of de-escalation. Anyone ever see these before? Yeah. So instead of you shall, right? Non-provocative. One of the sites I really enjoyed working at had a nurse who was famous for screaming at the patients, "You will respect me." It was really challenging to get her bought into all of this. So I don't think I ever converted her. But I definitely tried to explain why screaming, "You will respect me," was not going to work, especially with someone who's hearing the voice of a demon, telling them to be disrespectful or something. This person's already terrified, and you're kind of like, feeding into it. You shall respect personal space. Why not, right? We're trying to communicate to people that we're here to help, and we're going to give you space to hear us and have deep emotions and have thoughts and feelings that are uncomfortable, and everyone be safe at that same time. You shall establish verbal contact. Huge, right? It's not enough to, sometimes you're like, I don't know what to do, so I'm just going to do nothing. That could be the worst. You're probably way better off just trying any kind of contact, even if you have to go into it with humility, saying, I don't know what to say right now. You seem really upset, but I want you to know I'm here, and I'm listening. Even if that's all you do, to not be ignored in an emergency setting when you're suffering greatly, so much so that you came to a medical institution to save your life, to have somebody simply say that is huge. Short phrases, repeat yourself. Yeah, I think this is fairly obvious. Imagine the worst news you've ever received. Somebody tells you something awful. Somebody you love was injured. Somebody you care about has died. You're not hearing complex narratives. It has to be very straightforward. I'm here for you. We are going to keep you safe. Do you need a glass of water? Do you need a blanket? Just very straightforward. You shall identify the patient's wants and feelings. You shall listen, law down the law, and offer choices for what is next. I think of this similar to, like, I have 2 children who are now young adults, right? And so we all know what it's like when someone's dysregulated, and you can't do whatever they want, right? You're in a hospital, the police might have brought somebody in, they're on commitment paperwork, oh, this guy said he's gonna kill himself. And you can't say like, well, you can stay or go, but you can say, you can go into this quiet area and we can give you some medicine, or you can sit over here with a blanket and I can, I can sit and listen to you for 10 minutes, or you can give choices. I can get you water or juice. Sometimes just doing that, and you're not saying, I'm trying to empower you, I'm giving you autonomy, blah, blah. You're not saying any of that. But in that split second, you're saying, I'm going to either walk left or right, and I'm going to do what you want. You tell me. And that has unconscious consequences for people, that you're showing them, like, I'm respecting your humanity. Little things like that end up adding up a lot. You shall agree or agree to disagree. You're not going to get into an argument. You're not going to win an argument. There is no winning in this situation. Everyone's going to survive. And at the end of it, hopefully the patient's suffering is less. Your stress might be going up, but that's why you're there. You're there to be somebody who helps absorb some of this. You're not there for you, you're there for the patient. So you're not going to win an argument. You shall have a moderate show of force and be prepared to use it. So yes, we have to be safe. If a patient assaults us, we have to defend ourselves, and then not only could we get hurt, they could get hurt. I know this, I've been assaulted in my career a couple times, like really terribly, right? But in the end, that doesn't give me license to just assume, oh, well, this next interaction is going to be horrible, so I'm just going to surround myself with security. Well, they're going to see a bunch of security guards and big dudes with boots and official-looking things and decide, all right, the fight's on. That's how this is going to go, because you've communicated that already. That just makes it worse. It just increases the odds that you're going to get hurt, and the patient too. And you shall debrief with the patient and staff. Lots of publications on debriefings, what they're good for and what they're not good for. They don't treat trauma, but they do help inform how the systems can improve. And I really think they help solidify relationships between staff members to just say, I care about you enough to just literally ask, how are you doing? What did you think of that? And what do you think I could have done different? And what could I do better next time? And, invite that kind of exchange with each other. 10 Commandments. So as you approach, paying attention to all these things and thinking, might the patient think them an adversary, an enemy, an additional attacker? I like to remind my staff all the time with everything that makes up our economy, our government, our healthcare system. So often, not always, but often we are interfacing with other humans who see us as the haves, right? So chances are if you're working in a hospital, you have a home, you're getting paid, right? You have benefits, you have an education. And for certain folks within our community, they see themselves as not that. And they see us as seeing them as not that. We might as well be the correctional system as far as they're concerned, right? And it's just for some patients, they see us as an extension of that. They see us as an extension of the system that hurts them and abuses them and takes advantage of them. And we can't fix that. But what we can do is recognize that could be this person's lens. And if it is that person's lens, what if I was them? What would I want and need next? Some sort of acknowledgement that, yes, we're swimming in this economy and in this culture and these politics, and I can't do anything about it, but I'm still here. It's me. These are things you can do ahead of time to maybe decrease your tension. If you have a ring on, you might, it's got a diamond on it, you might turn it inside. If you're wearing a tie, you might either take the tie off or, tuck it in, so that if you're wearing if you have a lanyard that's not break free, you might take that off. You want to think about these things ahead of time, because if you're not thinking that ahead of time, you're going in like scared, like I should have taken my tie off, I should have taken my lanyard off or whatever. So just basically prepare so that that's not a thought anymore. Like you're just, you're calming yourself by preparing for the worst case scenario so you can go in with a different way of thinking. Identify exit, entrance, egress. Careful with preparations. They may assume that you're preparing to fight them. Yeah, you don't want to be walking in the room, taking stuff off or whatever. I think it's more about, when I think about when things have gone wrong for me, I knew ahead of time there were cues. And what I failed to do almost every single time was sit down with like 2 or 3 people and say, here's the game plan, right? This guy's paranoid. He has been for 3 days. I have to tell him his commitment's being continued and he's not getting his gun back. So we're going to do this in an open milieu, and you're going to be in that corner, and then you're going to be in that corner, and we're going to have, his, mom on the phone ready to go. Like we're going to have all, everything set up. If I had been thoughtful about that ahead of time, I would have been fine. It's really, I was moving too fast, right? And it would not have helped to go in the room like, all right, I'm taking my lanyard off, like, and him watching me do that. Like, that's not going to work. Non-provocative, calm demeanor, relaxed facial expression, soft-spoken. And if you're not in that space, give yourself a moment. I like to carry around, does anyone here like Thich Nhat Hanh? You know Thich Nhat Hanh? The Vietnamese Buddhist philosopher. I really like him. I keep a little book of his called Taming the Tiger Within. So when I'm working in the psychiatric emergency room and I feel the tension, maybe there's someone pounding on the glass, like pointing at me and saying, how they're going to beat me up when I come out to interview them or whatever. I give myself 5 minutes and I read until I feel my heart rate come down. Like I've got to, because I just know it's better. I'll make a better decision if I do that. So everyone, you want to figure out what works for you to get in that space, because none of us live there all the time. That's not real. A non-angry tone. You want to come across as empathic and genuine. Relaxed stance with arms uncrossed, hands open, knees bent. no cursing or insults, no matter what is said to you. There are moments where, if we don't rehearse that, we don't remind each other. I think a lot of that too is when you see a staff member do that, to not react necessarily in a punitive way at first, at least, to sit down with them and say, where'd that come from? Are you okay? Because that didn't help you or the patient, and it certainly didn't help me, to kind of get at the root of it. For those of us who are finding ourselves doing that at work with a patient, there's something that happened, and there's something you're afraid of, and that's fine, but you have to be able to talk about it, or the cycle just continues. It's a cycle of trauma, really. Personal space, 2 arms length, eye contact, super important, and offer a line of egress. In other words, you don't want to be talking to a patient in a corner with 2 security guards flanking you. You want to know, the patient should be able to see that they can walk. So if I'm talking to somebody here, that, maybe there's a bathroom or a day room over there, that there should be a way for them to walk away from me. If I need to tell them something and they don't want to hear it, there's a way for them to get out of that without hurting anybody. They don't have to fight to get past me to basically tell me they're not listening to me by exiting the room, right? So super important to do that. Expand the space if the patient is paranoid. Move if told to do so, right? So if someone is like, yeah, this is it, we're not talking, anything you have to say, you can say to somebody else, you can put it in writing, we're done. And I'm leaving the room, unless they're in a seclusion room and the intent is to, restrain, just, there's no point in arguing. It's only gonna hurt the patient and possibly you and your staff. Orient the patient, tell them who you are and that you are keeping them safe, right? So I find myself commonly reassuring people. I don't know how this is gonna go, but I promise you, everyone's going to get through this, but we're here with you. And we're all going to get through this shift. All the other patients, you, me, the rest of the staff that's coming in on the next shift, and we're going to do it together. But I've got to work with you to accomplish that. And so, and I promise you, this nurse I'm working with is tremendous. The social worker who's coming in tomorrow morning, I've seen her do wonders for people. And the benefit is you happen to, not only do I get the great opportunity to work with them today, you get to work with them, and so this is an opportunity. This is what I have. And today it's all I have, but we're gonna give it to you, everything we can from it. You will allow them no harm. That remind them if, for instance, the staff and security feel oppressive, we're not just here to protect you, we're here to protect them. And keeping the other patients safe is also what keeps you safe. That they're going to have regained control. I tell people all the time, I've never seen anybody stuck here forever. That does not happen, even if we wanted it to happen, right? The hospital administration wouldn't let me. The government wouldn't let me. The judge, who you would get to hear on the commitment hearing, won't let me, right? And so why would I want that anyway, right? So that's not going to happen. And I can't promise you if you're leaving tonight or tomorrow morning or the next day, but you will get out of here. And by the time this is all over, you're going to be safe, you're going to be healthy, and you're going to have a better trajectory than when you came in. Oh yes, one communicator. Don't have a bunch of people talking over each other. Identify who it is. And if you can find someone, it doesn't matter if it's the social worker, the nurse, the behavioral health tech. A lot of times the primary communicator on my units turns out to be some young tech who's been there for 2 or 3 years and knows the patients that are in and out, and they end up doing all the talking, and the patient prefers that because that's the one that's sitting on the unit with them last time they were there. And so it can be anybody, and as long as the message is getting across and the patient is benefiting from it. Here we go, yes. Repeat yourself. get the patient's attention, and do not confuse. Here we go. Yes, we mentioned this earlier. You know, do you want something to eat or drink? Can be really huge. A quiet place to go, a chance to talk about things. I often will pause to ask, you know, you've met a bunch of people here. Is there anybody here you felt comfortable with? And quite often a female patient will say, yeah, this, you know, the lady that helped check me in, I'll talk to her for whatever. Great, you know, if there's somebody up in triage who they just felt comfortable talking to. We mentioned I do telemedicine. Sometimes on telemedicine, the patient will only talk to me on telemedicine. They'll say, like, I'll be seeing somebody in Illinois or Oregon or whatever, and they're like, where are you? You know, I'm like, oh, I'm in South Carolina. They're like, oh, I'll talk to you. And it turns out they're like, there's no chance I'll run into you at the grocery store, so I trust you. And they live in a small community. They just don't trust anybody who lives within driving distance to talk to, right? And so now the telemedicine person is the person they're willing to disclose to. Other times it's the opposite. I don't even know where you are. You say you're in South Carolina. You could be making that up, you know. So it's kind of 50-50. But the point is, it doesn't really matter who, as long as it's a trained professional on your staff who, you know, is going to maintain confidentiality for the patient. That's great. Don't argue. Don't blame. Don't give orders. Don't bark orders. Go over there, right? I need for you to, you know, be moving to this side of the room because that's how we're going to be able to keep things safe. It is also where we can see where you are in case you have any needs, and we can, once you're over there, we can bring you juice or water. Which would you like, right? Don't up the ante. Listen and agree, agree, agree. Not in agreement often. See it from their side, right? So we're just trying to get through this, right? So again, this is not an argument to be won. This is a day to be survived. You can only help the patient if everybody is not disabled, not injured, trust has been maintained. And you shall listen, be quiet, give the other person time to think. Nobody likes a lecture. Don't belittle or minimize the problem. I have found often with psychiatric illness, often the stated problem is a true problem, but it's not the root problem. It's not, you know, when someone comes in and says, you know, well, my mom said something mean to me at dinner, you know, and now I feel suicidal. That's, you know, that's like the most recent thing. But once you get to know this person, you know, you find out they were in and out of foster systems for 10 years. They were physically abused. They were sexually abused. They have a partner who recently left them and took a bunch of money. And then they had to move back in with mom, who's always been critical and did not protect them from the foster system or the person who sexually abused them. And so all mom has to say is, you're not even trying. That's it, right? All that trauma from childhood comes flooding back, you know. And what, in the emergency room, we're very busy, right? You're like, what? Your mom was rude to you at dinner? And now you're here taking up my ER bed? And, you know, and you want a sandwich and you think you need admission? Like, this doesn't make any sense. Of course it doesn't make any sense. They're telling you what they're willing to tell you. And that's just this tiny little nugget of a representation of the things that have caused them to reach a place where they'd rather be dead if they weren't getting help from you. And so pausing and trying to be humble and remember that there's a backstory similar to that almost always, can really be humbling for us. And it's something we need to remind ourselves if we find ourselves wanting to minimize somebody's pain. Let them exhaust their list of wants and complaints. Sorry. My boss does that for me every once in a while, right? My wife is pretty good at it, I think. All right, introduce, ask, listen, and de-escalate. This little story is kind of cute. This man was dressed as a plant, making pigeon noises. at people walking by. I said hello, asked if it was okay to take his picture, and then asked why he was dressed as a plant. He said, I'm just working through some stuff. Thank you for asking. No one has asked, right? So it's a cute story, but it represents similar, I think, it's to what I was saying just in the prior slide. We have no idea the suffering, the origin of the suffering of others. We have to, and especially in a healthcare setting, we have to assume there's more. You shall lay down the law and offer choices, or for what is next. Set limits, establish what is acceptable, propose alternatives, establish consequences, right? So consequences are different than coercion, right? So we do have to help people understand often, you gotta let me go, I'm getting out of here. And I have to, coercion would be sign this voluntary paperwork, or we're gonna commit you, and rather than saying like, right now you're in a position where it's just you and me, government isn't involved, you're suffering, obviously, we're here to help you. And if you agree to let us help you, we will help you. If you happen to bust out of here and go running down the street, guess what's going to happen? Somebody who's worried about you is going to call for help. And ultimately the police are going to get involved. And then I have no control. They're going to do whatever it is they have to do. In my experience, they have to bring you back here. And that's going to involve a lot of pain and suffering. And it's no longer just about you and me trying to figure out if you want juice or risperidone or lorazepam. It's a whole bunch of other stuff, and you might get hurt in the process. Right? So super important to make clear that just because you're not coercing them doesn't mean you don't know how this might go if the patient finds themselves drifting this way instead of that way. You're trying to help gently set the stage for them making a choice that results in the least amount of suffering. You shall offer choices, use positive reinforcements, time out, quiet time, chance to get away from stressors. Honesty is good. Tell it, yes. I don't know how many times I've said that to people, and I've seen it work almost every time. Just take a step back and say, I feel really frightened by how you're behaving, the things you're saying. I'm just telling you, So having the courage to be vulnerable enough to say that is huge. It extends a lot of humanity, and it gives the patient a chance to understand. I'm not saying you're bad for what you're doing. I'm telling you how I feel. I feel afraid, and it doesn't feel good. Do you understand why that might be? Can you help me? Because I don't want to feel this way. You probably don't want me to feel that way. Let the patient know that arrest may occur if they injure someone. Right, just being honest. Like, look, if somebody gets hurt, if you're on a commitment and you run, if you've threatened to hurt somebody and you run, it's no longer in my hands. I don't know what will happen next. There's a legal system that just takes over. Right now we can do that. We can make that not be. We can just focus on your treatment, and why don't we stay in that space? You shall agree or agree to disagree. Don't be afraid to say I agree as many times as you can. If asked to agree with the delusion, right, I'm here because the FBI is trying to take all my money, and they have bugged my broken cell phone, and I need you to fix it. You can say things like, I'm not there to experience what you are, but I agree you are experiencing it. Clearly that's your experience. I don't understand it, but I get that that's where you're at right now. That must be very frightening. I have nothing to, I don't work for the FBI. I don't know anything about your phone and what it's connected to, but I can imagine that's scary. Maybe you would feel less scared while you're here if we offered you some olanzapine or some lorazepam. Would you like an option for a pill? Or maybe you're somebody who's just feels more confident to get a shot because you don't even want to. You want the psychological belief that it's going to work better if you get a shot. There's plenty of patients like that, to give them that choice, and just work that through with the patient. Can we agree to disagree? Moderate show of force. May be able to escort to a quiet room. Avoid takedown when you can. Recognize that 2/3 of staff injuries are related to agitation that occurred during the takedown, right? So they don't occur in the initial strike, right? So we engage in takedowns with injury at twice the rate of us getting injured when we're not, right? So it's not a benign thing, and we're not necessarily preventing injury by doing it. Sometimes we're inflicting it upon ourselves or the staff. Restraints only for danger to self, lock seclusion for danger to others, right? So if someone is trying to hurt themselves and they need to be restrained and given medication to decrease the odds as they're trying to do something to hurt themselves in the hospital, you don't have to lock the door. In fact, we want access to this patient as they're restrained. If their intent is to harm someone on the staff, maybe it's a little different, right? And so we don't have to lock the door and restrain the patient every single time. You shall debrief the patient, the staff, and the milieu. Identify what led to the episode, what could have been handled differently. Strategies to prevent future restraint or seclusion, suggestions from the patient. Ascertain whether the patient's physical well-being and psychological comfort were addressed. Maybe sometimes you can find there's somebody who wasn't even, you thought was not involved in the process, was watching the whole thing and can pull you aside and go, you know what, you came in and you were hurried and you said this, and then this person came in and didn't know what room they were in and got the patient name wrong, and then the next person came in and asked the same series of questions for the 4th time in a row, and they can kind of like tick it off. Often it's for me, often it's a behavioral health tech who's like sitting at a wow station who's like what's going on? And they have if you pull them into the debrief, you're like, oh, our process could have solved this. We could do it better. Ensure other patients know that they are safe. Oh yes, very huge, to debrief with the rest of your patients in your milieu. Like, I'm sorry you had to see that. Are you okay? And often just engaging that person and acknowledging what they're experiencing and how scary that might have been for them to see it or be afraid that they were going to become a part of it is very important. Can be traumatizing to both patients and staff. Early identification and intervention using de-escalation techniques in collaboration with medication can prevent the need for seclusion or restraint, right? So often when we're offering medication, we're anticipating that if the patient is not getting medication in them one way or the other, this is where it could lead. And that's part of why it's so important to empower people early. And we talked about earlier, juice versus water also. Hey, you don't have to get medication right now, but I'm thinking that if we get it to you now, the odds that you're going to be feeling better go up. The odds that tension gets to the point where someone ends up forcibly medicating you, maybe not on my shift, but next shift, go down. Would you like a pill? Would you like a shot? And I learned very early the number of people who actually prefer shots, and it's not a struggle if they tell you, like, oh yeah, I want a shot, although most people are preferring pills, and how nice is that you're handing them a pill as they're, very upset. And how many times, I can't tell you how many times I've had somebody yelling at me, I'm going to punch you in the face while they're, taking Ativan, and then 2 hours later, they're like, sorry, I said that, and, you're so glad that you just, took the time to listen. So like, oh, that is how you're thinking and feeling. Thanks for sharing it, right? But if you're not leading with aggression, you're instead leading with the compassionate lens and trying to avoid injury, you can use these techniques and get there. All right, we have a couple cases to go through. Case number 1, 50-year-old male with a history of bipolar disorder is brought into your ED by a local police department after getting into a fight with his wife, ultimately picking up a knife. His wife denied any substance use for the patient and stated he is well managed with his medications, but he stopped them after he was laid off from his job and lost his insurance last month. Anyone ever seen a patient like this, even one time in your ER? Like, yeah, I would be shocked if you have an emergency room and this is not like, oh yeah, I saw him yesterday. Has been medically cleared and transferred to the EmPATH unit. And yay, you have a beautiful EmPATH unit here. I was so excited to see it. So now you can imagine these cases, not just in your emergency room, but also in your EmPATH unit. After being an EmPATH for 30 minutes, you approach him for assessment. He is noted to be fidgeting and starting to get loud. He becomes increasingly frustrated by the questions being asked of him. All right. So any thoughts about, like, where would you start with this patient?
Offering him a drink? I mean, water or juice?
Yes, empowering him. I think offering him medication is the first thing, because look at the story. The story is that this guy, when he's employed and he has access to his medicine, I mean, we have no reason to not believe his wife, right? I mean, he threatened her with a knife or had a knife when they were arguing, and she's still there, which tells you, like, she probably knows, like, hey, when he's treated, he's, nonviolent and he's the person I love. So you're probably going to say, like, hey, I hear if I had met you 2 months ago, you would be fine. And what was different 2 months ago? You were on your meds. Let's just get this going, You're in the place you need to be, and we have the thing you need. Why don't we get going with this? Why don't we start there? So I would say that would be my first thing to offer it, And you can decline. I try to not use the word refuse. Refuse is trying to suggest that we have power that we don't necessarily have, right? You can decline, or you can accept, but it's your choice. I think if you accept, we're going to get you on the right trajectory, and it's going to show everybody that you're trying to get out of here, right? Not just me, but the whole staff. And if you end up on a commitment, it's going to, the judge is going to ask me, Dr. Harmon, is he taking his meds? And if I say, yeah, he is, there's a pretty good chance the judge is going to go, well, I don't think you really have rights to hold him. He's agreeing to take meds. He has access to them now. So I'll go through that whole thing with patients and say, this is how it works, you'll be able to tell him, I'll be able to say, like, yeah, he's telling the truth. He's taking his medicine. So you want to start by offering medicine in this case. Case number 2, involuntary patient arrives at the EmPATH and immediately wants to leave, becoming more and more agitated. Patient states he should never have been brought to the EmPATH unit. Shouting, it was a big mistake. He starts to threaten and posture towards the staff. Staff immediately swarmed the patient, arms folded, and yelled at him to sit down. I have worked in this facility. What de-escalation principle was not followed? And what technique could be used? Any ideas? What were they not doing? So they don't respect his space, right? We're saying moderate show of force. People kind of like lingering, basically communicating, we've got this, we're in control of the situation without seeming aggressive. We don't want to come in like a SWAT team, right? This is not a criminal. Whether or not this person has ever done something that, I see this all the time too. People are like, well, we can't have him in our unit. He's a criminal. He's a human being, and when he's in your hospital, he's a patient, right? I was speeding down the interstate yesterday. I broke the law. Am I a criminal? Is that who I am? It's a thing I did, but I think it's not who I am. I hope not, right? So what technique could be used? Use a calming voice, take a step back, have your arms down, offer choices, be empathic. Wow, it really seems like you're suffering. for you to be yelling at us like this. This must be an awful day, you know. I don't have much, you know, but I do have time and energy. I've got some sandwiches, I've got some juice, I've got medicine we could give you. Once everything's cooled off, we can help you make a phone call to your best friend, your spouse, you know, your case manager, your therapist, you know. But we gotta bring down the tension here so that everybody feels safe. Once the staff feels safe, you know, we're afraid right now, but once we feel safe, then we can get to the business of helping you. But right now we don't feel that way, you know. So that's the other one. All right, so there's a example of a EmPATH unit, very much like the one here, which is so great. So yeah, there's a lot of publications out there. Project Beta, which Dr. Zeller helped publish, the first emergency psychiatric set of guidelines, or Project Beta. Dr. Zeller was the lead author of a series of publications. I got to meet him because I was fortunate enough to help co-author one of the articles. Actually, I was working for Carolina's health system at the time, but I did it because I got connected to the folks through my friends at UPMC, and so now it's really cool to be down here, and there's, you know, MUSC, and here in the central part of the state, there's attendings that I've met along the way, and so there's a lot of crosstalk, and everybody's sharing all this information. It's still having an effect. The last thing I'll mention too, if you're looking for, you know, additional ways to think, I recommend educating yourself about what's called trauma-informed care. Anyone here ever heard of trauma-informed care? Trauma-informed care basically says almost everyone you're interacting with has been through some sort of traumatic experience. So just assume it. If you're wrong, that's rare, and it won't hurt anybody. If you just simply assume how you're thinking and behaving is because of something horrible you've been through, that's almost always true. All the defenses we learn in childhood, we bring forward into adulthood, and they quit working, right? And that's how marriages fall apart, that's how coworkers don't get along, and it's how patients end up in our emergency room. The other thing is I recommend studying nonviolent communication, Marshall Rosenberg. It asks us to learn to speak in terms of our own vulnerabilities and our own needs, and the power of dropping your guard and just saying, you know, I'm just a human with needs, and I'm going to let you know what those are. You know, I'm not worried about you know, what you think of me here. I'm going to just own this, and I'm not going to tell you what to do, and I'm not going to judge you. I'm just what I'm going to say is I'm a human with needs. I'm going to tell you what they are, and I'm going to ask you if you could possibly help me meet those needs. Maybe you can't, maybe you won't, but that's it. And so I find when I study trauma-informed lens and nonviolent communication, not only does it help me with patients, it helps me with the other staff members, and it's a lot easier for them to feel vulnerable around me and tell me when they're afraid. And I feel then safe with them to tell them when I'm afraid. And it's a lot easier to get on that Black Hawk with the Special Forces guys and a bunch of weapons and talk down a guy with a loaded machine gun. You know, like, where do you find that, right? You find that by trusting each other and deciding that, you know, shared humanity is more important than anything. It's the only way we can help people heal, is to live in that space.